Thank you, Colleen, and good morning, everyone. Thank you so much for the invitation. Like Colleen mentioned, I am the director of interventional pulmonary at StatCare in Knoxville, Tennessee. I've been here for the last 2 years after my fellowship at Sloan Kettering in New York for the advanced year of IP, and so far it's been great. I started the endobronchial valves or the bronchoscopic lung volume reduction program in Knoxville. We started off in February of this year, and we've already done 15, and I have another 2 coming up in the next 2 weeks. So I'm just going to talk a little bit about it. These are my disclosures, and just an extra one. I realize that I'm surrounded by very able and capable RTs. I did have stage fright as a child, but that has sort of gone away. So if you find me falling down on the floor, please don't intubate me. It's probably because I wiggled on that. So, all right. These are our objectives today. We're going to talk a little bit about how the BLVR works and what happens in COPD and what the BLVR or bronchoscopic lung volume reduction does to reverse it. We're going to talk about not every single patient with COPD gets this, so who can actually get it. We're going to talk about how the procedure works and what the data shows in a very brief way, because obviously there's been a lot of studies on these. And a little bit fun at the end is just some of my procedures that I've done over the last couple of years that has nothing to do with the valves, but has something to do with more with IP or with interventional pulmonology. So let's begin by just the pathophysiology and how the BLVR works. So I'm sure that most of the patients, most of you all, have seen this patient. This elderly gentleman, very heavy smoking history, just quit, but he has very significant upper lobe predominant emphysema, and he's very short of breath. The PFTs don't look pretty at all. They just very significantly low FEV1, a lot of hyperinflation, can barely walk 100 meters. He's maximally medically treated. He's on 3 different inhalers. He's been through pulmonary rehab. He's on steroids. He's on azithromycin, and he's still just short of breath. So as the next step, you may want to consider, let's say this is Mr. E, for lung transplant. Or would you want to send him for lung volume reduction surgery because his upper lobe predominant emphysema? But he says that he doesn't want any kind of surgery at all. Like he's just scared of the surgery. He doesn't want anything. So what are our options over here? And that's what we're going to discuss today for majority of my presentation. I did not realize this graph when I moved in here 2 years ago, but I know this is 2018 data. I don't think that it's gotten any better in the recent future. But this is the graph for COPD prevalence in the East Tennessee sort of like region. And you can see all of the red stuff, all of the red is this heavy COPD prevalence. It goes all the way up in the Kentucky border and in Virginia, I believe also. I'm still getting used to my anatomy, also my geography over here. But I do get patients from the Kentucky border and also from the Virginia area that have come to me for valves. So it's a very, very heavy prevalence of COPD. Now, what happens in COPD? The main concern that we have, which leads to their debilitation, is the air trapping and the hyperinflation. COPD is the leading cause of death worldwide. It's actually the prognosis and quality of life. I know that all the focus is on lung cancer and state shifting, but it's actually the prognosis and the quality of life is worse for some of these patients who have really bad COPD. And I couldn't believe this number when I saw it, of $49 billion in direct medical costs were directly associated with COPD in 2020, which is a significant amount of money no matter where you are. We have a couple of pictures over there. The one on the top over there is just a microscopic picture of what healthy alveoli look like. And you can see this picture down here. You can see how destroyed it is. There's no interstitium and it is not as elastic as a normal lung parenchyma should be. So what happens in emphysema? There's destruction of elastin and collagen, and that leads to decreased elastic recoil. What that does is that the airways tend to collapse during forced exhalation when there's positive intrathoracic pressure. And this is due to a lack of tethering effect on these airways by the interstitium. This leads to decreased radial traction on the airways that causes gas trapping and hyperinflation. All of this causes the diseased portion of the lung, as you can see on this picture over here, to balloon up. This causes pressure on the diaphragm because of hyperinflation. So the diaphragm becomes flat, and it's not the round mound, that we need to be able to exert ourselves. It doesn't only put pressure on the diaphragm, it also puts pressure or compression of, I would say, normal lung in inverted commas. There is emphysema in that lower portion of the lung, or the non-disease, or the less diseased portion also, but it does cause compression of that lung, and there's less air going to that area, less blood flow going to that area, so there's areas of VQ mismatch, that more air is going to the upper portion, but there's not enough blood flow, so you're getting unoxygenated blood that is traversing through your body, and that's what's causing you to be out of breath, hypoxic, and just not being able to perform your ADLs. This leads to this vicious cycle that we get with hyperinflation, which causes shortness of breath, which makes you not perform as much activity as you would like. That causes reduced exercise capacity and even more breathlessness, which again causes you to not being able to perform your activities. You're essentially bedbound, or just performing very slow or small walks, which leads to deconditioning. And that in turn leads to the high risk of mortality, because you're predisposed to infections, COPD exacerbations, and being on a ventilator, amongst other things. So we have known about this for a very long time, about what needs to happen, or what happens with the hyperinflation bit. So there were very, very early attempts in 1972, and even before that, to address the hyperinflation. This was what they thought is that it's all because of pressure and in the lungs, so we need to just remodel the chest wall. So they tried to create more space in the front of the chest by causing an incision and allowing the lung to expand a little bit more. But I believe it was lost on them. It was the hyperinflation that was the issue. And this part is really, the line at the bottom is really eye-opening. The alleged benefits of these maneuvers were lost on the patients because they were so short of breath because of this that they couldn't argue with their physicians. So this is obviously, this has not gained any kind of popularity over here. Circle back or circle ahead about 30 years, and lung volume reduction surgery was thought about. So the first attempt at any sort of thing was attempted again even before that prior paper that I showed in 1957, but there was a 20% risk of mortality, so it never really gained any kind of traction. So about 4 decades later, Cooper and his colleagues in 1995 proposed technical refinements, which included a median sternotomy, a bilateral staple resection, rather than a unilateral thoracotomy like that other paper or the other person tried to do in 1972. But basically, rather than resizing the chest wall, they wanted to resize the lungs. Just remove the bad portion of the lungs, which will just reverse everything that we spoke about earlier about how emphysema affects your breathing. It increases the elastic recoil, increases the radial traction, decreases diaphragmatic flattening, and it redirects ventilation and perfusion into the better portions, of the lung. So they undertook a major trial, which is called the NETT, or the NET trial, which some of y'all may have heard about. They took 1,218 patients with bilateral emphysema, with pretty significant COPD, as you can see with the FEV1, the TLC, and the ARV. Surprisingly, there was no difference in survival at 2 years, but a significantly higher 90-day mortality in these patients. Now, why that was the case, I don't think that they've really looked into it as much, but I would presume that these surgeries did not take 45 minutes to an hour. They took a long time. You can see the PFTs up on the screen. That's the baseline PFTs on these patients. Putting them under general anesthesia, under muscle relaxants with these was not ideal. So they did a subgroup analysis, though, to try to see was this really true. And what was interesting was that patients who had upper lobe predominant emphysema plus low exercise capacity, even post-rehab, those were the patients who actually benefited from lung volume reduction surgery. But non-upper lobe predominant emphysema or homogeneous emphysema, and those who had high exercise capacity, they had the increased mortality almost 2 times more over here. It was just a lot of complications during these surgeries. 58% had at least one complication. A third of them had major complications due to ventilation issues. Some of them had a trach, some of them had failure to wean, reintubations. At day 30, 28% were still in the hospital, which is quite significant. 90% of these patients had a pneumothorax with a median air leak duration of 7 days, which is again quite high. And about 13% of them had a prolonged air leak of more than 30 days, which you can see why, because of all of these factors, that lung volume reduction surgery never really gained a significant amount of popularity. The whole physiology behind it was very sound, but obviously because of these things, it never really picked up pace. So how can a pulmonologist, or in my case, an interventional pulmonologist help? And we're going to go over how we're going to go into segment into BLVR now, or bronchoscopic lung volume reduction, which is minimally invasive way of doing what the surgeons were trying to do. And I'm going to go over first which patients can actually get this procedure. Because it's a very stringent criteria. It takes, when the patient comes to me, it takes about 4 to 6 weeks for me to really look into everything that I order, and I'm going to go over all of that. But the first thing I want to introduce to you all, and some of you all may know about this, is a concept of collateral ventilation. It's basically looking at the fissure of the particular lung, or both the lungs that we're going to try to target. This is a better diagram of a similar thing that I draw for all the patients that come into my office. Basically, what you're seeing over here is that you get interlobar connections amongst the different segments of a particular lobe, but the most important thing is the interlobar channels, or the incomplete fissures. Now you can imagine if I place valves in this upper lobe over here, no air will go in, but the air can sort of go down to the lower lobe and circumnavigate its way back up, and the valve is not going to work. The whole goal over here is to cause lobar atelectasis, relieve pressure, and if we have this fissure that is not intact, then it's not going to work. Now, there was a paper that was done where they tried to visualize the fissure by themselves and try to see if this would work, and they apparently couldn't predict it no matter how good your eyes were. So Pulmonx, or the Zephyr valve, that some of y'all may have heard of, came up with this Chartis balloon, which basically simulates what a valve would do. It has a flow sensor at the end of it over here. So before I place, after all the testing is done, just before the valves are placed, every patient gets this. I'm trying to see this flow go all the way down to 0 over here, or at least down to 6. If it doesn't, if this is the graph that I get, that means the patient is considered to be CV positive, or collateral ventilation positive. If this is the graph in the bottom, they are CV negative, and we can proceed with valves. If they're CV positive, then valves is not going to be for them, at least for the next couple of years, because I'll speak a little bit about there's a new trial that's upcoming, it's already underway in Europe, and it's going to be coming to the USA, where there's a product known as Aeroseal, which you inject it into the airway via the bronchoscope, and it sort of seals the fissure. It has some very promising results going on in Europe right now, so I'm hoping the next 2 to 3 years that some of the patients that I've said no to in the last year or so, if there are still candidates, then they may be able to get that. This is a very good algorithm that I found for how to select a patient. Advanced COPD, we already discussed, optimize medical, completely optimize their care. Get a PFT. If the PFT criteria does not meet, you can consider them for lung transplant. But if they do meet, you need to see if they're a heterogeneous emphysema or a homogeneous emphysema. If they're heterogeneous emphysema, and if we do a chartist on them and they're CV positive, we already discussed that that's the subset of population that was actually benefited from lung volume reduction surgery. So you can consider that. If they're CV negative, they absolutely should get valves, because if it works, it really changes their lives, and we have experienced that over the last few months with some of the patients that we have done. For homogeneous emphysema, it's almost a similar thing. CV negative, you get valves. And with CV positivity, there are some coils that are present that are not being utilized quite a bit. These were all done before, but not a lot of people are doing them. So I'm just going to try and focus mainly on the valves for the sake of this talk. This is my selection criteria for the patient. So obviously emphysema. BMI needs to be less than 35. They need to be on less than 20 milligrams of prednisone. Non-smoking for at least 4 months. I cannot tell you how many of my patients have actually attempted to quit smoking when they've read about the valves. And this is a very good motivator if there's none that you can find for the patient over here. You need a 6-minute walk test. They need to walk at least 150 meters or 100 meters if they're a homogeneous emphysema. PFTs, which all of y'all, we rely so much on, on y'all to get these for us. It needs to be in a body box, because that can give you the correct assessment via plethysmography of what the RV and TLC is, because those are the two most important criteria. If they're heterogeneous emphysema, you need an RV of 175%. If you have homogeneous emphysema, you need an RV of 200%. Having said that, I did a patient with an RV of 198%. It's semantics in the end at that point, and I'm not going to deny a patient life-changing therapy because they're off by 2%. We need to get a high-resolution CT, or what we call in our thing is CT for BLVR protocol. It's extremely thin cuts. This we uploaded to what we call as Stratix, which is the software from Pulmonx or from Zephyr Valve, which assesses a lot of things, and I'm going to have that on the next in a couple of slides, and a perfusion scan. I get some ancillary testing. I get an echocardiogram. I want to make sure they don't have pulmonary hypertension. If the PASP is high on the echo or they have RV dysfunction, I send them to my partner who does pulmonary hypertension. They get a right heart cath to confirm whether they really do have pulmonary hypertension, and if they do, it depends on how bad it is. I've taken a patient with mild pH for the valves, and it's been okay, but if it's moderate to severe pH, just putting them under anesthesia is a very, very high risk, and that's not something that they should be going. They should probably be referred to a heart-lung transplant at that point. You do an ABG, you need to make sure the PCO2 is less than 50, and the PO2 is greater than 45 or 50, and this needs to be done on room air for at least 10 minutes. And the most important test that I order is called a quantitative perfusion scan, which is basically a VQ scan, but I ask them to tell me how much perfusion is going to each zone of the lung. I want to make sure that the zone that I'm targeting or the lobe that I'm targeting is not getting a lot of perfusion, because if I block that off, yes, with time it will remodel, but for that duration, that much oxygen is not getting any air, that much blood flow is not getting any oxygen, and you're going to get a significant amount of VQ mismatch, and you're going to get a lot of hypoxia intraoperatively and even just immediate in the post-op setting. If you have two possible targets of left upper, right upper lobe, for example, you can decide, the VQ scan can help you decide which lobe is getting the least amount of blood flow out of the two of them, and you can target that. This is what a StratX sort of looks like. It tells us three things. The first line is the fissure integrity over here. That's this line over there. So you can see on the right side, the fissures, at least by StratX, is not very great. But the left side is saying it's 100% fissure, right? So they would probably be able to get valves on the left side. It gives us the destruction score at 910 Hounsfeld and 950 Hounsfeld units, which just tells me how much emphysema there is. I want to target the most diseased lobe for the most part that I can. And then it gives me the volume, which also helps me determine I want to target the area with the most amount of volume. Now, if I were to take this patient, for example, it would make sense that, that the left upper lobe would be the ideal target over here. But we have to keep in mind, and as some of you may have heard, that the risk of pneumothorax is very, very high in these patients. If I target the left upper lobe and they get a pneumothorax in the left lower lobe, they're reliant on their right lung, which is not very, very good. So that's what they're breathing on, because the left upper lobe is gone. There's a pneumothorax in the left lower lobe, so we don't know how bad that pneumothorax is. And now they're breathing on this very, very diseased right lung, so this patient may actually not be a good candidate in a way. I would actually target the right side. I would do a chartis on the right side and confirm this is not there, and then you just have a conversation with the patient whether they really want to proceed with this. It just depends on what stage of COPD they are in. Are they candidate for lung transplant? Are they not candidate for anything else? And I tell them this can go terribly wrong. I want you to meet all of your family members, get them, because this may be the last time you see them if you really want to go ahead with this, because this is a Hail Mary in a way. Some of them say yes, and some of them say, I want to wait another couple of years because I still think that I can spend some quality time with my family, which is fair. I'm going to go to the procedure now. So these are all the ways you can do this. I think we're going to just be focused on the valves, but there's some fibrin glue sealant, there's airway coils, and there's some thermal vapor ablation. There's some new procedures that are coming out in the field of COPD, which are bronchoscopic and which is ablation related. But they're still, again, not FDA approved completely, so you have to stay tuned on that one. This is how the valve works.
The Zephyr valve procedure is performed under general anesthesia or conscious sedation, where a standard bronchoscope and flexible delivery catheter are used to guide the valves into the target lobe and desired airway. Multiple valves are implanted to ensure complete occlusion of all airways leading to the target lobe of the lung. Valves may be placed at the lobar, segmental, or subsegmental levels, dependent on the airway anatomy. Trapped air in the treated lobe escapes through the Zephyr valves until the lung volume of the treated lobe is reduced. The valves can be removed and replaced if needed. After treatment, the remaining lobes can expand more fully, and pressure on the diaphragm is relieved, improving breathing mechanics and overall lung function.
I want you all to keep in mind this whole, how the upper lobe sort of like collapsed and this lower two lobes sort of like expanded. You saw this valve, this is the actual footage of a valve that is placed, and you saw it was, I call it singing. It's really reassuring that it's working. You can see when it's open, air is coming out, and when it senses that air is trying to go in, it just closes. So you want to see that in the procedure. These were all the trials that were done. Again, this was the LVRS surgery that we spoke about earlier, but there have been multiple trials, upper and lower lobe disease, heterogeneous and homogeneous emphysema. I'm just going to focus on the two main ones. The Liberate trial is the gold standard. That's what we use for guidelines. And then the impact, I'm just going to speak about it because of the homogeneous nature that it went after, or the patients, even with homogeneous emphysema, that they try to target. This is the Liberate trial. It was one of the largest multi-center randomized control trials, 190 severe heterogeneous emphysema patients. You can see that the FEV1 was about 28%. So it's very, very low. DLCO was about 34%, again, severe. RV was 224%, very, very diseased patients around the age group that you would see them, in their 60s, and some of my patients, a couple of my patients are actually in their 50s also. So they basically underwent a 2:1 randomization where 2 patients got valves and 1 patient got standard of care. And the primary endpoint was a change in FEV1 of more than 15%, and you can see more than enough, it did that, a 47.7% increase in FEV1. And this was sustained over a 12-month period. It started to decline a little bit, but it's still sustained over standard of care. You talk about secondary endpoints of the residual volume, you talk about 6-minute walk tests, you talk about SGRQ score, the Bode index, and the MMRC. And even at a 12-month period, they're all sustained. Obviously, the most dramatic effect is there in the first 45 days to first couple of months, but the effect is still sustained. So it was a resounding success. This is the most famous graph, I think, in the world of BLVR, is the risk of pneumothorax. As you can see, this is in the first 3 days is when you see 76% of your pneumothoraces. And this is the reason why we keep our patients in the hospital for about 3 days after the procedure. The first day, they get about 4 or 5 x-rays every few hours. The next couple of days, they get a couple of x-rays every day in the morning and evening. And the last day, they get a PA lateral. They get a wristband or a wristband that says high risk for pneumothorax. They're warned about their red flag signs and told to come in straight into the ER if there's any issues. I see them in 7 days after their valve procedure. I get an x-ray on that day, because even at day 7, you can still see there's a risk of pneumothorax. If that x-ray looks good, then we get a 45-day CT, and we repeat the PFT, repeat all the other testing that we did before, again, at day 45 on this. So the next study was the IMPACT study. Again, these were homogeneous patients. Again, still significantly low FEV1 at 28%. But the RV criteria, like we mentioned before, needs to be 200% for these patients and not 175% to get some benefit. Again, very, very severely sick patients. But even in these patients, there was a 18% reduction in, 18% improvement in FEV1. There was about a 28-meter improvement in 6-minute walk test distance. And there was about a significant increase in the SGRQ score also for them. Again, there's about a 25% risk of a pneumothorax in these patients, which you can understand why that would happen. I totally don't remember that video that we saw from Zephyr, where the upper lobe is reducing and the lower 2 lobes are hyperexpanding. If there are bullous or there are small blebs on the edge of those lower 2 lobes, as they're hyperexpanding, they're going to pop, and that's how you get the pneumothorax. And that's the whole reason behind this, and that's why we keep them in the hospital for 3 days. The whole thing is, if it's going to happen, it usually happens on intraoperatively, or it happens in the procedure. And that all depends on how good the fissure is, how long does it take. I always fear that the charters become CV negative quite rapidly in the first 30 seconds, because that means that lobe is going to collapse quite quickly, and the lower lobes are going to have to expand quite quickly. And that rapid expansion, I fear that when it takes me when it makes me work to put the valves in, I actually like that, because it's going to take the upper lobe time to collapse. It's going to take the lower lobe time to expand, and it may adjust a little bit more. So I have a very heart-to-heart conversation with the patient that there's a 1 in 3 chance of a pneumothorax, this is 25, so it's 1 in 4. The other studies have shown a 33% risk of pneumothorax, so it's anywhere in that setting. I go over the scan and I make sure that there's no large bullous that this can be there. So, and I tell them what their risk probably is. This is just a summary of key studies. We already discussed the Liberate trial. We discussed the IMPACT trial. as you can see, it's been a resounding success throughout the board, where there's been an improvement in the FEV1, there's been an improvement in the exercise capacity, and there's been an improvement in the SGRQ score. So there's an objective evidence, and there's also subjective evidence. Some of them don't meet this. I've had a couple of patients, but they tell me that they feel a lot better. What's considered a success is I need a 50% reduction in that 45-day CT in the alveolar volume to be considered a success. If it's less than 50%, the valve may not be properly positioned. There may be a leak somewhere, so I may have to take them back in again, take a look at all the valves. Unfortunately, even though all the fissures look intact, everything looks intact, 30% of the times the valves just don't work. And we don't know why that is the case. It may be something to do with the fissure integrity, obviously, but we have done everything that we can to try to confirm that the fissures are intact, but it still doesn't work sometimes, and this is just unfortunate for the patients. We only do unilateral for now. There are some centers that do bilateral, but the second lung will go at 6 to 12 months. It won't be right away. The aggressive ones will do it at 6 months. The more conservative ones will do it at 12 months. Then these are some of the exclusions. If you have airway disease, if you have a lot of mucus plugging, it's just going to block the valve. It's not going to work properly. And I've had a couple of these patients where I didn't really look into that as well. So we had to go in and remove some of the valves out and put them on the opposite side, or just remove them because they're just not working. If you have bronchiectasis, it's going to cause the same thing. It's just going to cause a lot of mucus production. If you have a lot of paracipral emphysema, you're just asking for a pneumothorax, which is not going to heal. So this is a major contraindication. If you have a big bulla that's occupying more than 30% of the hemithorax, that's the contraindication. Lung fibrosis, obviously, again, because you're going to have all these bullae again at the edges, it's going to cause a pneumothorax, and it's going to be scarring. The lung is just not going to expand back, which is what we want over here. If you have lung cancer, suspicious nodule, that you have to understand that lobe is going to get atelectasis. You won't be able to measure anything in that lobe ever. So there are cases of lung cancer popping up in lobes that were small. So if there's any nodules that are present, then you got to watch for its entire time, whatever the protocol is, before you go ahead and place valves in that area. And obviously, if you find something accidentally, like this gentleman over here, a lady has a dissected aorta, so you don't want to be placing valves in these patients for obvious reasons. So this is just a step-by-step approach. We mentioned about the PFT, CT scan, put it to Stratix, just look at that, get all of the other testing, like the VQ scan, echo, and the ABG, put them for the Chartis procedure. Again, the Chartis and the valve is done in the same procedure. I don't bring them for a Chartis first, and then I don't want to put them on anesthesia 2 times. So if the Chartis is a go, we place valves right away. And after that, 3-night hospital stay for observation, 7-day visit with me, and then a 45-day visit with the CAT scan and PFTs and 6-minute walk test, just to see if there's been a difference. And then I follow them every 3 months after that. I'm just collecting my own data. I may or may not publish it, but it's just good to give the patient objective evidence. Sometimes it's all in the head, like we always say. If they see that, it may actually benefit them, but they may not have the actual belief. Just a little bit of things that are really passionate to me now is just, I'm just going to talk about some of the cases that are not related to BLVR over here. So, and most of you all would have seen some of these patients. So this is a 54-year-old lady who's been diagnosed with asthma for most of her life, worsening dyspnea, treatment failure, all kinds of allergy shots, and she's just unable to lay flat. And we get a spirometry in the office, as flat as a hamburger would be. So we're already suspecting this is going to be tracheal stenosis. We go in and bronch her, and that's her airway. That's about 3 to 4 millimeters. I'm not even able to pass my PED scope beyond this. So it's that's what she's been breathing through, and she's 54, no intubation history. So this is what we call idiopathic subglottic stenosis. So I start to work on it with a cautery knife, just sort of like, this is the ideal case because it's thin and it's web-like. I cut a little bit more, and you can already see it's a lot of improvement. The put a balloon past this, and it almost looks like it was never there. So this is from 4 millimeters to about 16 millimeters, so that's a 400% increase in airflow. If you all know, Poiseuille's law is inversely related to the fourth power of the radius. So you can imagine how she felt. She comes to my office a week later and she's high-fiving me. She's like, my husband doesn't complain that I sound bad. I went hiking for 5 miles, and she could never do any of that before. And now she wants to lose weight also because she's become obese, unfortunately, because she just couldn't do anything. This is some of you all that may have seen it again. This gentleman who had tracheostomy because of COVID. He's tolerating a trach collar and a passenger valve, and he just can't be weaned off of it. So they call me, and I put a bronchoscope from the top while the trach is still in, and this is the opening that I see. I'm like, this is the reason why you can't tolerate, why it can't be decannulated. I thought it's the trach putting pressure from the front, which is what's causing all the crowding. So I removed the trach, and it's still small. So again, we go to work on this. First, I just didn't know where to cut. I can't see anything over here, so I just put a balloon past it, and I get it up to like 8 or 9 millimeters. Then I can see these walls that I need. I don't know where you need to cut the most tension point to release the pressure off of it. So we start making those cuts. This is my widget bronchoscope. It's my weapon of choice. And then we go in, and we're at 16.5 millimeters again. I pull the trach out. He goes home. Unfortunately, he had a recurrence of this, so I had to redo him again in 6 weeks. But this is from intubation. He's had 2 or 3 intubations in the past, and sometimes you just need this to be surgically corrected. Or you put a stent across this for the airway to remodel at the size of the stent. This is a 69-year-old gentleman whom my partner refers to me that he just has progressive dyspnea and cough, heavy smoker. That, if you're wondering, is the right mainstem picture. So that's the right upper lobe right there, and that is the right mainstem with the bronchus intermedius behind it, and the carina is right here. And some of you all might think just put a stent past this and just open it. My goal is to try to avoid a stent at all costs. 30 minutes later, it's all gone. There's still tumor in the right upper lobe, but I've saved 2 other lobes over there, more air going, and the radiation and chemo will take care of the other lobes. There's no need to be a hero, like you've already done what you're meant to do. So you keep going ahead, you may push something or you may remove something which you're not meant to remove, and it's going to be bleeding and you won't be able to control it. This is one of my favorite cases. I did this post-nights after my night shift for about 2.5 hours. This lady comes in for hypoxic respiratory failure and severe chest pain. Some of you all may think, is there a pleural effusion here? But to the keen viewer, you can see that the trachea is moving to the side of the whiteout. That means there's atelectasis over there. And you can, if you see closely, you can see there's like a wedge sort of like this over there in that trachea, which is coming out into the distal trachea. So I put a bronchoscope in, and I see this. I show this picture to my wife, and she goes, "This looks like a potato." I mean, I don't know what kind of potatoes we are having, but I hope that I never have these kind of potatoes ever. So after the first swipe, I take a snare across it, and I remove the main part of it. You can still see there's a lot of tumor over there. I debulk a little bit more. We reach the right middle lobe and right lower lobe, which is already looking a lot better. We put a balloon past it, we dilate it, and this is where we are at. I showed this to my wife, and she goes, "Oh, you fried the potato." I'm like, I can never have chips in my life now, or fries in my life now. So, and you can imagine how the patient felt after, and this is the most satisfying case. Like this, this is why you do what you do, I think. This is another one, 76-year-old lady with worsening. She had a history of chemo rash to the right hilum. She had non-small cell lung cancer. And this is the bronchus intermedius. It's just so small. Again, this I couldn't pass my Pete scope beyond. This was about 4 millimeters. So I put a balloon past it, and I dilate it, and I see the right lower lobe opening, but I can see there's so much, it almost looks fibrotic. I don't know if you all can appreciate that. It's just very pale. It's just very resistant to me. And I felt this is just going to bounce right back in a few days. So I actually just put a stent past it. And you can see a lot more airways. She felt like a complete difference. You can hear a focal wheeze on her before, and you couldn't hear any wheezing after. I pulled the stent out in 4 to 6 weeks because the stent started to like migrate a little bit. It caused some fibrosis at the end over there. So, and I bronched her like 2 times after that over the next 6 months. And this is almost like having a balloon in there for 4 to 6 weeks rather than just having it for 30 seconds, which is what I do it for. And it looked perfect, and she's very, very grateful for that. This was an unfortunate gentleman who had cancer in the past. I got immunotherapy, got chemo XRT. This is the distal trachea, and this is the anterior tracheal wall, and you can see this necrotic sort of like fistula to the anterior mediastinum. I scoot my way past this over here, and I see the carina. Obviously, I didn't do a good enough job because there was some oozing from that area. But I see that everything else is quite patent over here, so I just need to cover this up. So this is the place where I put in and I actually go into that hole, and this is what I see. I call my attending from Sloan Kettering on the phone, and I'm like, this is where I am, I'm trying to biopsy that, and he's like, just GTFO, please, from there. Like, do not biopsy this. This is necrotic, but I could see something pulsating in the background over there, and you don't want to find out what that is. So I put in a Y stent across, a silicone stent. You can remember this was the carina before. This is the carina now. This is the same view of that first picture that we saw, the distal trachea. And as we go through the stent, we wave by to the fistula, which is fully covered. And now the patient has a 1.5 centimeter trachea. At the beginning, they had a 6 millimeter trachea at the start. Some of you all may have heard the robotic bronchoscope. I know most of the hospitals now in East Tennessee have sort of just gotten it. Blunt just got it recently. But these are the kind of nodules that we're going after because of this. This is an 8 millimeter nodule sitting on the aortic arch, which would never be biopsied in the past. But we have an intraoperative cone beam CT in the room, so when I reach that area, I take a spin, and I can see this, my needle is just superior to it. I know I'm supposed to go inferior, but the more inferior I go, I'm going to hit the aorta. So this one takes a lot of diapers, when you're doing cases like this. And this is my final angle. Like, I don't know where the aortic arch sort of is, but we got a diagnosis on this patient. They got radiation therapy, and they have a cure with this. And this is my last one. So you can see it's by the diaphragm, and it's right there. The first thing I thought about when I saw this was the robotic bronchoscope. So traditionally, like, this would have taken a surgical resection to get this out. The patient was even like, he was actually hiking 2 or 3 miles every day with the diaphragm excurting, and was sitting next to a blood vessel. I don't know how nothing happened, but this is the robotic bronchoscope. So I try to target. I put the target on, instead of a nodule, I put it on the needle, and it was right there. So it was a brad nail. The patient was putting up Christmas decorations. He had the nail in his mouth. He fell down, hit his head, lost consciousness, and aspirated this needle, and it was there for 3 months before anybody found it. And we only found it because he got some bronchitis, which has nothing related to do with this, and the PCP got an X-ray. So that's the robotic bronchoscope. We go in. You can see it very clearly over there. We just pull it out. I try to fit it into the scope, but the scope is very small, and it's meant to be small to get out this far, so I just pull the whole thing back, holding it really tight. And you can see the respiratory variation, so the whole time the patient is actually under a breath hold. I'm just letting him breathe so it doesn't move. When he put in the nail 4 months ago, it was silver, and this is what it looked like at the end of it. And that is it. Thank you for your time. I'm happy to take any questions there may be. Thank you. Do we have time for questions, I believe? Right.
Yeah, any questions? We have a few minutes.
Gentleman in the corner. Yes, you can. You gotta test for it. You gotta make sure that and they need to be on treatment for it also. So yes, alpha antitrypsin can get these valves also.
Renee, did you have a question?
How often after doing the valves do they end up with like thoracotomies, resections? Do they end up having those?
They don't need
They don't
the
come after.
no. It's bronchoscopic. It's doing the same thing as what the surgery would do, but this is minimally invasive. The procedure takes about 45 minutes. So after that, they usually would not need it. If the valves haven't worked, I have to take them back and revise the valves, which happens in 30% of the patients also. But they usually don't need a thoracotomy after that.
Any more questions?